All right, part two of Brandon and I's discussion on intra and intersession decision making. We're using section 19 of the Muscle System Specialist courses. I have a reference for that. Remember, we talked about kind of the whole idea of intra-session decision making and what you do in between sessions, and then we had all kinds of causal factors that we were considering, or why the body system that we are working with shows up the way that it does. We try to explain that and talk about how do we move wherever they are now to improve their voluntary motor control, whatever they really want for their body and their use of their system, and what the basics of a repetition looks like, and fatigue and potentiation and all the different things we can affect potentially, and then how we might just basically work through a low quality configuration and progress through that, some of the choices we have. And that led us off to kind of looking at our toolbox, all the different ways we have to kind of interact with the musculoskeletal motor control system and start to get a read on where it's at and what it can do and how we might improve it. And so we've got kind of I guess my attempt at describing, categorizing, and understanding some of these different approaches and tools that we have. And they're not in alphabetical order, but we have a bunch of them, right? The QMAMC, different kinds of voluntary contractions, myo-isos and plyos. And then we've got single leg squats and cervical effects and temporal mandibular joint, and looking at the respiratory mechanics and standing trunk motion and balance and eye motor and CPG, and looking at the glossus motor, even the tongue system, and of course the SARS system action reaction screen. So lots of things that we can bring to bear on the process, just independent even of the traditional view of pick a name of an exercise, do some set, rep, rest interval of it, and move on to another name of an exercise and do some set, rest, rep interval on it. Right? That's, I don't know if I'm oversimplifying that, but
no, you're spot on, man. I mean, this is what it's all about.
Most people do, right? And so the QMAMC, Qualitative Manual Assessment of Motor Control, is our version of assessing individual ability to create torque in order to meet and equalize an external applied torque from some bodily configuration. So the general premise of that is, can someone achieve, maintain, or regain equilibrium for some level of perturbation to their system? And we have a whole course on that and a whole discussion on that we can't get into now. And some of the reasons we might think about doing that is if we see asymmetrical range of motion and some motion to position, to discover positive or negative findings in terms of quality, in mirror image paired range of motion assessments across the bilateral symmetry line for the human body. And we use it for pre-intervention decision making, see whether or not we want to do anything with it, how we might do something with it. We might use it to test the efficacy of our intervention. Did what we do improve the quality of the motor output? Again, gain an understanding for assessing that sense of quality. So got to be careful with this. Precautions are applying a force with a joint in a fully closed or fully open packed position. The ends of its structural capabilities could be risky due to the tensions or compressions on the internal materials. Applying a force into joints with known or suspected pathology, got to be careful about. Making joints with disease and injury contract all the muscles and put forces into the tissues, and we use it for, again, asymmetrical range in response to our SARS stability and interpretation of our SARS, and when we want to assess configurational stability or things in the history like we talked about in the previous part, injury, chronic issues, occupation, sport. So you know, important tool. Are you using the QMAMC
Every day, all day.
all day? Yeah.
QMAMC, SARS, all of it.
Yeah. How are your clients reacting to that process? How do they seem to respond to getting pushed on and talking about how that felt? And
They love it. I mean, the clients responded incredibly positively to, to using this type of intervention for a long time. I mean, they love the checks and balances and the changes that can be seen intrasession. I mean, they love it.
cool.
Yeah.
Yeah, it's a
What about yours?
good field tool. Yeah, for sure. Yeah, again, they get it for sure, and it gives them a personal experience, and they like it that they get to have some input into the conclusion. Hey, I liked it, I didn't like it, that felt better, didn't feel better, right? And so yeah, they seem to understand and appreciate at least what we're trying to do, given its limitations as a tool, but they definitely like the potentials of it. And that we can, do a pre and post process. Did it change or not, versus assuming it changed the way that we wanted it to change. So,
I think you said something important there. Let's talk a little bit about the limitations.
yeah. Again, the limitations are that it's qualitative. It's a subjective experience of both the practitioner and the client. We're kind of interpreting what we felt in our body and our own muscle system, and they're trying to interpret and report what they feel. And so anytime you have a subjective tool like that, there's some error, you can't be as super precise as maybe a quantified laboratory setup where you're really controlling tons of variables and isolating independent variable interactions and taking a quantified measurement of that interaction of some sort. And so that's one of the limitations. It's hard to exactly duplicate, repeat QMAMCs, right? And as well, the QMAMC is a stimulus and could be changing the system as we're doing it, right? So it doesn't have that super objective quality to it. And so, okay, that's fine. And again, I would point you to, we did a entire session on the QMAMC and its potential and its limitations and how to be careful about interpreting that. So, but the qualitativeness, the experience, I think is important and can give us information that quantified tools cannot, for sure.
Right.
For sure.
Agreed.
Yeah. I mean, the client doesn't care if, we've improved their force output at some point of application of a dynamometer pre and post, if they don't like the way their body feels in the process. And so that's a significant limitation, I think, of objective only, quantified only, assessment. And we want the quality side of it dealt with, because it's how they feel in their body that's more important than the numbers, right?
Absolutely.
It's always interesting to me, you have a 25-year-old superstar athlete who could probably produce, for some configuration, 50 foot-pounds of torque, right? And I've got an 80-year-old lady in a similar configuration who can only produce 10, and we can improve the quality of that motor output, and even though they're both producing totally different quantified values of torque or force application, they both can report that they like the way their body feels. It feels better when they use it. And so the qualitative subjective conclusion about how they feel in their body is totally independent of how much torque they produce relative to each other.
Well, the curve's getting lifted for both of them, right? So it doesn't, that curve being lifted can feel good if it's 10 to 15 or 45 to 50. It doesn't really matter.
That's the thing. That's the thing about it, right? We can't, to say, oh, well, you've got to be producing 80-year-old lady 50 pounds of torque here in order to feel better. No, you don't. No, you don't. It might only be 5 pounds of torque extra, but her sensory system, her brain and central nervous system perceive it as, a vast improvement in capability for what she does with her body and how it works. Right. So
she may not need the amount of output that the athlete needs. I mean, so it's relevant. She's just going to feel better from the little improvement.
Yeah. And then we have, in terms of other tools, our versions, our descriptions of contraction shortening, contraction lengthening, contraction maintaining joint angles, linear distances between muscle attachments, and our myometric voluntary active is kind of our initial go-to. Can the central and peripheral nervous system control motion, create motion, control it with whatever inherent boundaries are set? And it's just an indication of voluntary motor control. Can they contract, shorten something? And that's just a basic idea for giving us a sense of how well someone controls themselves. Prereqs, if you don't know their allostatic load, or allostatic load is less than or equal to 4, we might consider just doing a myo. If you want to determine end of active range for QMAMC in a mode, just have them kind of voluntarily take themselves wherever they can go, and that's their current end of active range, and we might start there with a QMAMC or some point just past or just underneath that. Post mode determination of increased motion and symmetry. You can have voluntary control myometrically after you do something, and maybe confirm your work without increasing too much joint stress and tissue stress. Precautions, again, being careful at the ends, fully closed, fully opened pack. Position, shortening of a muscle in all 3 planes. When you really shorten a muscle all the way, you've got some neurological issues there and some mechanical disadvantages potentially created if that's possible. And then obviously posture and plyometric loading. Being careful about performing a myometric and seeing that the plyometric side is loaded. Pain in motion, compensated motion, quality of motion issues. Do they have the full availability along their continuum of motion? And maybe other control issues that you are considering. So yeah, my best attempt at least beginning to describe some of those categories of issues using tools. Understanding that in a living system, when you're doing a myometric voluntary active, you're doing a plyometric voluntary active on the other side. As the joint moves, the other side of the joint axis, those tissues are lengthening. Now, whether they're contracting and lengthening, it's a different issue, right? Whether just passively lengthening, those are the other ways of manipulating these modes. Who's opposing, who's not opposing a particular opposition of force. So yep, do a lot of myos just to watch how people move. ISOs, submaximal again. Can they just contract and hold a position, hold a joint angle at some configuration, maybe to create potentiation? Isometrics have been shown in the research to potentiate tissues even submaximally. Can develop positional stability at some specific position of configuration in some plane, some position. So that's a good thing to do the ISOs with. Pain-free positions, allostatic load again, being careful about that. Isometrics. It's interesting. Isometrics are sometimes often avoided with individuals with high blood pressure, although isometrics have been shown to lower blood pressure. I don't know if you've seen that.
Yeah, I have. I was going to say that doesn't make any sense because it's been shown to decrease high blood pressure conditions over time. The research has shown.
Yeah, unless they're, sometimes you'll see it isometric with Valsalva, right? A really hard, like abdominal internal pressure contraction. But yeah, I always thought that was interesting. Swelling, edema, right? Could increase the stress technique for drawing out maybe a weakness. I should change that word to low quality. You can do it pre-myo if you want, and pre-plyo.
Give an example about the increased stress technique for drawing out.
Well, yeah, it's those the longer duration isos can do that, right? Like we showed with your hip flex.
Oh yeah, yes, of course.
Like, oh, wait a minute, there's something. That's why the word weakness here is not really the best word. I should get rid of that word. It changes the quality of the force output. So, yeah, that's how I would think about that. And you just don't know at what duration of isometric that can occur. Joint position being, again, fully closed packed, open packed. I start with a low level of contraction, usually, 20% RPE and 5 to 10 seconds, and I increase that duration for each subsequent rep. And you can manipulate, obviously, how much force. And then if they're low quality for a QMAMC for position configuration, I might use an ISO right away, or I might use the myo first. And you're always thinking about gravity's effect on limb weight and segment inertia.
What makes you decide what you're going to use first?
Usually the background, the history, and the conditions. So if somebody's got, pain in a myometric through a myometric position, I might say, let's not do any. I don't want you to do repetitive myos here. Why don't we just find a place in a position in the plane, in the pathway that you're pain free, and start with an ISO as an example. And then plyo, voluntary actives, right? Again, you're going to put increased stress on joints and soft tissue structures to stimulate potentiation. And it can do that very well. I've seen plyometrics potentiate, raise quality dramatically, just at that level. Again,
I have too.
Consider allostatic load. If you've exhausted ISO and myo modes and you're still not getting the quality that you like, you can try the plyo, voluntary active, or there's no quality change in the QMAMC findings, and there's still maybe asymmetry, and you're trying to figure out why. Might not be the shortening side, could be the lengthening side. That's keeping the asymmetry. Could be joint structure, but it's an attempt, another way to attempt to see if you're trying to figure out if bilateral symmetry is possible for configuration and joint displacement. Precautions, again, high allostatic load. Be careful about plyos. They're a little stressful. They create DOMs, right? Delayed onset muscle soreness. ISOs can do it too. Hard ISOs can create,
no doubt,
DOMs. Got to understand joint structure boundaries. Again, those fully terminal ends of closed and open packed, and shortening or lengthening of muscles in all three planes. And there's the DOMs. Reference and indications for use: cleared or attempt to clear a local range issue or quality control issue, but sensations or asymmetry persist. So again, using myos and isos, and it's just not really taking you in the direction you want. Try a plyo. You try a plyo on the muscle, the myo side tissues. You could try the plyo on the iso or the other side of the joint axis, the plyo side. So I usually do both just to see. And you know, it's such a strange thing. And in the course, I give you the research I've seen on, you know, just the mere fact that each of those modes have different neurological governing strategies. And that's interesting to me. I wish we could see the motor units and the sensory units, what they were actually doing for even the same tissue, right? Because, you know, you normally think, well, okay, what controls muscle tension development? Firing frequencies of motor unit pools and how many units are recruited determines tension, force. And what's interesting is apparently determining tension biometrically and the motor unit strategy and firing frequencies and the unit recruitments are not the same as in a plyometric in terms of firing frequencies and recruitment strategies. And it sort of makes some sense in that the plyometric side, you know, there's the elastic energy storage part of it, and that's contributing obviously to the control process. So yeah, again, I've seen that work incredibly well in many scenarios, right? Once they get good at contraction lengthening, they move well.
Yeah, and it just feel the muscles and the joint space, everything just feels really good a lot of times after you go plyometrically or voluntary active or involuntary active, especially when they can get to the point where they can tolerate that.
Yeah. And then we go through and describe, you know, myometric voluntary passive, where, you know, that person's, the subject's letting you move them, contraction, shorten, change joint angles. They're not actively developing tension. Might give you some more information about the joint, gives you some tactile feedback and end feel to get to the end. If you need to control compensated motion from an active range of motion exam, or assess differences between limb and trunk motion, between active and passive modes, you know, how far can they move when they contract, and is that different than when they're not developing tension? Again, allostatic loads. I usually wait before I do a lot of passive motion, again, because of the potential joint stressors. If they're less than 5, I tend to work through active range till their allostatic load decreases or their complaints are less. And I need to know structural range and limit for a degree of freedom. How far can they go? So I'm holding I'm moving them to some end position. So more risk associated with that.
It's important though, sometimes, you know, when they can tolerate it, to see where what their actual boundaries are passively.
Yeah.
Because a lot of times there may be a pretty significant gap between what they can do active and what their joint structures would actually allow them to do if they could get to the full available end range.
Yeah, absolutely. And, you know, whether or not you want to try to close that gap, right, and say, let's see if we can get your active and your structural allowances and your active capabilities more, I guess, synergy or complementary. Understanding joint structure, yeah, shortening, joint pathology, got to be careful. If they're having difficulty performing an intended motion, you might use a passive motion to help them, or some active assisted version. Compare, contrast active to passive, and if you want end feel information, you want to know what the end of that joint range feels like. So plyometric involuntary active single joint. This is where you're strategically using the lengthening of an agonist group across a single joint axis. I guess you could do more than one joint axis through a plane to assess an agonist's ability to maintain a shortened position. Following a myo mode to assess tissue tolerances. You have persistent range asymmetry without suspect of structure limitations. Previous work not maintaining post-acute response. So some of the stuff you've been doing with all the voluntary isn't really maintaining session to session. Try the involuntary plyo. Again, allostatic load. You got to understand joint structure and where you are in these packed joint positions and what shortening or lengthening means in all three planes. And then if there's joint and tissue pathology, and you can create a lot of DOMs with that too. So
I've got a question, and I think that's important. We talk about this part where it says, persistent previous work not maintaining acute session response. I think it's important to note that if you're going to go involuntary, you may need to warm up that configuration a little bit. Maybe do some ISOs or myos just to get the quality up a little bit before you just jump into the involuntary plyo.
Yeah, I would agree that it's not the lead mode to attempt when you're working with the system. I agree with that because it's a higher risk, probably higher risk even than passive joint range of motion because of the stress on the materials. And if they fail, it's essentially failure, right?
Right.
You're making them fail. They're maintaining tension, but they can't stop you, and they might just give up, and you just keep pushing. And just like when you're driving a car at 50 miles an hour and you decide to stop, by the time your brain says, I'm going to stop, and your instructions get to your foot and your foot pushes on the pedal and the hydraulic lines get loaded, and then you start stopping when 100 feet have gone by already, right? So 100 feet of road. So you've got to be careful about that. Yeah, so again, back to another mode for trying to help them improve quality or range. And then you can do it with multi-joint. So that was single joint, same thing with multiple joints. And then we can get into, maybe next time we can start talking about some of these screening procedures. So, and I could add even to here, right? I don't think I have isometric co-contractions listed. I'm gonna make a note about that. Yeah. Have you been using co-contractions at all?
I have. I've been using those for a long time.
Yeah, those work real good too.
They do. You'll see. I mean, maybe they'll have it, and then all of a sudden they co-contract, and it's just the blank spot again.
All right, man. Good.
All right. Good.
Yeah, we'll schedule.
Let's do another, and we'll just keep working through